Faculty up here to the panel for the discussion. We have about 12-13 minutes until the break starts for discussion. So before I open the discussion for the audience, I have a few questions to some of the faculty. One is for John, actually. John, you mentioned screening intervals. Can you tell us a little bit about screening intervals in relation to the polyps, when you find polyps, when you do polypectomies, the size of the polyp, the pathology of the polyp?
Sure. So for screening intervals from polypectomy, if you're removing a polyp that is an adenomatous polyp that's greater than 1 centimeter in size, I think certainly greater than 2, between 1 and 2, there is, I think, a little bit of debate. The follow-up surveillance endoscopy is generally recommended to be 3 months, and then if that is clear at that time, a year after that for initial follow-up, and then routine follow-up after that every 5 years.
I think this is important in the future also for legal reasons because, and I'd like to have your opinion, John, also. I think far too many endoscopies are done for screening and the intervals are too short if you look in general on the endoscopies, right?
Yeah, I agree with that. You have to ensure that the polyp is completely removed, and sometimes it's difficult to do that, although chromoendoscopy, because of the time I can get into a lot of the newer techniques, chromoendoscopy and other things that can help discern precisely what's adenomatous, what's not adenomatous when removing a polyp. I think it's just, screening is very interesting, and I think it will be very interesting as further data on large population studies come out over the next 5 years, whether colonoscopy will continue to be the screening test of choice for colon cancer.
Quick question. Should we all get chromoendoscopes, or do we continue to watch this? Obviously, it's very strongly used in Japan, etc., but is that type of screening useful in the United States, and should we all have these in our units?
So who is for chromoendoscopy routinely for screening colonoscopy? Raise his hand. Thank you. I have a question to Gary. Actually, a couple of questions. So you mentioned complication rates after biliary stenting. If you have a complication and you realize that complication during your endoscopic procedure, how would you proceed? Would you try to treat this complication immediately endoscopically, or go to the OR? And if you go to the OR, if you would do it open or laparoscopically?
A very good question. There are 2 complications that you might find endoscopically. One is perforation and the other is bleeding. Bleeding is definitely best treated endoscopically with localized injection. We try not to use too much cautery because you can get into the pancreatic duct orifice, but I think injection followed by a short burst of heater probe application to the apex of the sphincterotomy. Now, perforation is different. There's 2 types of perforation. One, if you do enough of them, eventually you will have a perforation of something in the greater curvature of the stomach, or something where the side viewing scope in someone with some altered anatomy gets caught. If you find yourself in the peritoneal cavity, I would not try to do clips. I would take them to the OR and sew it closed. In my career, which goes back to the late 80s, I had one elderly lady with that category, and very thin-walled stomach. Now, the other more common thing is a perforation of the sphincterotomy. And many times you can't tell that it's happened, but if you do see retroperitoneal air, which you can see on fluoroscopy during the ERCP, we usually do not try to enclose that in any way with clips or anything like that. The procedure should be stopped. If you have access to the biliary tree at that time, it's good to place a biliary stent so that it'll shunt any bile around that and it won't go into the retroperitoneum. Then the decision for surgery versus A conservative approach, which is antibiotics and observation, for me, it varies. There's not really good data to tell you which way to go. If it's free perforation with a lot of intraperitoneal air, and then quickly fluid, between loops of bowel, I think all of those patients should be operated on. And because I think and I'll tell you what we do, but if it's retroperitoneal, small to a modest amount, I think that is, without a lot of fluid, it's acceptable to treat that with antibiotics and observation only. If you operate, I've had to help defend surgeons who've operated and had terrible outcomes because they open the duodenum and try to close the perforation. That is really usually not necessary. You simply do a Cochran maneuver and place a drain behind the duodenum in the area of the leak. You want to get into the leak. You want to create an external fistula, and that fistula will close almost all the time. I think it's not a good idea to try to fix the leak with sutures either posterior to the duodenum or intraduodenally, because the patients have more complications, can get pancreatitis and have problems. So I think that answers your question.
Yes, absolutely.
And I don't think that laparoscopy is the best way to do this, but if you're a very aggressive laparoscopic surgeon, I would think that you could do a Cochran maneuver and place it behind there. The problem is getting into the right plane where the leak is located is a little difficult. I prefer just to do open with a gallbladder incision.
Now, this is an interesting question. I'd like to raise this question to the faculty. Who would treat a biliary complication, as Gary mentioned, a perforation laparoscopically if they need to go to the OR versus open? Who would do it laparoscopically? So I'd like to open the discussion for the audience. There's a question there.
I have two questions, one for Dr. Hazy and one for Dr. Vital. To Dr. Hazy, could you just comment further regarding the contraindication of a PEG in the setting of malnutrition? And for Dr. Vital, my question is, when I was doing training, transluminal drainage of a pancreatic abscess was felt the wrong way to do things, and that those should be drained percutaneously. And has that now changed?
So let's start with Jeff first.
I'm going to answer, actually. I want to chime in on the second question. We do those. We drain the abscesses all the time. If you can get to it with an endoscope, drain it into the gut. It's a great way to go. Saves the patient an external drain. As far as malnutrition, once patients get below 2.1, 2.2 with an albumin, I'm a bit reticent. Part of me, I always want to know why they're malnourished. Are they malnourished because you're doing a palliative procedure for cancer, and their malnutrition isn't going to get any better even if you start feeding them? Or is it because they're getting irradiated for head and neck cancer, and they just haven't been eating for a while, and it's kind of an acute malnourishment versus a chronic? Acutely malnourished patients, I'll tend to go ahead and put a PEG in them. Chronically malnourished patients, I'd be much more reticent to put a PEG in it. Number of other issues obviously fall into that. Thin patients, obese patients, I tend actually to favor putting them in thin patients rather than obese patients. A malnourished obese patient is looking for trouble. I don't have an absolute number, an albumin or a pre-albumin or a transferrin number. I differentiated between acute malnourishment and chronic malnourishment. Acute malnourishment, just meaning they're not eating, chronic, cancer, or they've been malnourished for a number of years.
Gary, about the pancreatic.
Yes, I think the short answer is correct, as Dr. Hazy has said, but the little longer answer is this is a changing landscape. I don't think that in many areas, transgastric drainage of abscesses is being done. Pseudocysts, yes, but if you're talking about infected necrosis with a white count, I think that's got to be a committed group who has both surgical and endoscopic capabilities to manage the patient. You have to try it, see how they're doing with their white count fever, if they're having septic course. And then if you're successful, you may have to go back and redrain it. So it requires a lot of attention. But the short answer to your question is internal drainage avoids fistula, that the external drains almost always do. Number two, we're making a pretty big opening that we progressively enlarge. It allows some of the necrosis and liquefied material to come through. The percutaneous drains don't have that. They're a long track and a thin tube, and they get clogged up. They don't work really well. So I have found that only maybe 40 or 50% of patients will do well with that. But there is a prospective randomized trial in the New England Journal, which you should read from this last year, AHBPA, which was presented in March, April, where they started in Europe with an external drain, and then progressively stepped up to internal operative debridement as necessary, and found they could reduce complications or reduce hospital stay by that approach. I would agree with Jeff that if you can do it transgastrically, you'll get a much higher percentage of success, as our data would indicate in a small number of patients. But it is not standard of practice yet. It is a changing landscape.
One quick question, one last question for Dr. Smith. Dan, if you mention intraoperative is very important for the gastric remnant, what would you think, what is your standpoint on routine preoperative upper endoscopy for bariatric patients?
Yeah, I think ideally you'd get that. The challenge has been getting coverage or payment for that. So you have to have a pathologic diagnosis to justify a preoperative EGD. But even reflux, patient has had chronic reflux. So I try to get every single one of those patients to get a pre-op EGD. If I can't rationalize it, then I get an upper GI to look for hiatal hernia, and then we do serologies for H. pylori.
Thank you. There's one more question.
One quick question on interop colonoscopy post-resection. Are you checking leaks on all resections, left-sided, right-sided?
Yeah, so I don't, I kind of spend most of my life at the other end of the GI tract. In looking at the literature and the colorectal surgeons at my place don't routinely do it, except for low anteriors. But there's discussion now based on some of these emerging data that, you know, maybe we should be thinking about looking at every one of these anastomoses that you can comfortably get to with a scope. But I'd be curious to hear what the colorectal guys here think.
I'm not routinely doing it. I think it is a great practice. Actually, Morris Franklin, if you ever hear him speak, he advocates routine endoscopy for every one of his anastomoses, whether it's a right or a left-sided lesion. We do it for the left-sided lesions. We don't do it for the right-sided lesions because at my institution, quite frankly, it's a matter of equipment. We just don't have the equipment. I think you have to be a little careful, especially if you're doing it laparoscopically. If you have the ability to use CO2, it's better, because the distension that can occur from doing an intraoperative endoscopy going from all the way to the right side can make it difficult, even if you find something, to fix it laparoscopically, because once the colon's blown up, sometimes it's hard to decompress it. But it's a great technique, it's a great tool, and we probably should be doing all of it on every one of our anastomoses, because I think it'll help us find leaks.
Thank you so much.
Quick comment, our guys in bariatrics do it routinely, and they say once out of a while they find a major staple failure that they hadn't appreciated just visually looking at it. So.
Thank you so much. We have a very quick break now for about 10 minutes, and we reconvene here for the second block at around 9:20.